Great. So, once again, very good morning. And let's start with the new topics of abdominal pain. Last time, I think we covered many things in abdominal pain, right? Especially concentrating to acute pancreatitis, right? So, now we can start this scenario. Uh, uh, Listen it carefully, Dr. Fatima, how you approach, tell me. A 28 years old woman present to the emergency department with lower abdominal pain for 2 days and mild vaginal spotting. Her last menstrual period was 7 weeks ago. She reports a history of previous PID, that is pelvic inflammatory disease, right? And one spontaneous abortion. On examination, her temperature is normal, pulse is 110 per minute, blood pressure is 98/60, abdominal tenderness in right iliac fossa, guarding present, speculum minimal dark vaginal bleeding, bimanual cervical motion tenderness, right adnexal tenderness, fullness, urinary pregnancy test is positive. How you manage the case? Dr. Fatima, I would like to give the comment in 1 minute. We'll do practice exactly the exam, right? So just take your 30 seconds, organize the answer in your brain, and just 1 minute, max 2 minutes. You have max 2 minutes to answer these questions. Then we'll discuss in detail. We'll dissect each and everything. But I want to know, if this question comes in your exam, how you supposed to answer in 2 minutes.
Hello, sir. Am
Yes,
I
start now.
audible, sir?
Yes, audible. Go ahead.
Okay.
Yes, Fatima.
My internet was breaking.
Let her answer. Then I'll come to you. Yes,
Okay, sir.
Dr. Fatima.
Sure.
Yes, please. Start now.
She is a 28 years old woman in a childbearing age. She presented with a 2 days history of vaginal spotting, and her LMP is 7 weeks ago. And she has a positive history of PAD and one spontaneous abortion. It is a strong history of uh, ectopic pregnancy, and with the signs and symptoms like she's having pulse of 110 and BP is around 100/60, so she's in shock. um, by doing a physical examination, her abdomen is tender in the right iliac fossa with a minimal vaginal bleeding, and her PV examination shows cervical motion tenderness. It's strongly suggestive of ectopic pregnancy with a ruptured tubal ectopic pregnancy. So we have to stabilize the patient first.
How you
We have to
stabilize?
start with first we have to start with ABC. First we have to start with oxygen, and we have to secure IV lines, and we have to start with the IV fluids.
And that's it.
And we,
You want
and
to
we have
start
to
IV fluid.
do a USG scan for her
Mhm.
to confirm the diagnosis, whether
Mhm.
the
What you can see in the
uh,
USG?
whether the
What are the
uh, s-
findings in the
sac
USG?
the sac where is the
Where?
sac exactly
Sac where?
in the adnexia, where is the sac,
Okay. So one is sac. What
whether it is
else?
viable or whether the sac it is viable or non-viable fetus.
How do you confirm it is viable or non-viable on USG?
By seeing the cardiac activity, sir.
Okay, cardiac activity. If no cardiac activity, non-viable. Cardiac activity, viable.
Yes. Yes.
Okay. What else?
And the sac size.
Hmm.
And we have to do a
Why you
beta
want to know this? Why you want to know the sac size?
to decide whether it is a medical or a surgical treatment, whether to
Mm-hmm.
go for medical or surgical treatment.
Mm-hmm. So when by size, if you go by size, at what size you decide it's a medical management and at what size you decide it's a surgical management?
Less than 3.5 centimeters.
Hmm. It is what, less than 3.5 surgical or medical?
Less than 3.5 centimeter is a medical treatment, sir. And it should be non-viable. And the beta HCG should be less than 3,500.
Okay, fine.
And the
So
patient
what I
should
understood,
be stable.
okay, so what I understood, we are talking about this case only, not other case.
Okay.
So for
Uh,
this patient, what I understood, you going to go for ABC, right? Airway, breathing, circulation, IV line, you secured it, IV fluid started, right? What would be the next management for this patient? ABC
we
is
have to
done
go
very
for
well.
a, okay. We have to
Hmm.
start the IV fluids and we have to do a USG scan, sir. A
USG
transvaginal.
is, USG is done, TVS is done, transvaginal sonography or transvaginal ultrasound
Okay.
is done, which confirms the
Okay.
ectopic pregnancy, right, in the fallopian tube. Now, what's your next plan? You were
Mhm.
thinking clinically, now it is confirmed on USG, right? Beta HCGs as per your, I mean, the level in the blood, right? So now what's the next step? You confirm it 100%.
Next, next step is
What
immediately we
do?
have to refer the patient to gynecologist, sir.
Okay, refer to the gynecologist. You are working in a gynec team only, right? There is
Yes, yes, sir.
gynecologist is on the leave on Saturday, Sunday. You are alone. What would be the plan? What would be your plan? So you are not treating the patient, but you have something in your mind how you manage. Yes, yes. I'll switch to Salika. You think over it. Yes,
Yes.
Salika. So how you forward this case? This patient is with you. Classical history, examination, vitals, speculum examination is there. USG, you did it. It's suggestive of ectopic pregnancy on the right side. How you manage this patient?
Okay. So this patient is going for rupture and she's in shock right now. So after stabilizing the patient must be shifted to OT for immediate surgery, sir. So if a gynecologist is not present in our center, we should immediately refer the patient for another center for where gynecology is present, and she might need emergency surgery, sir.
Okay. So which
She's
surgery
in
you supposed to do for this patient? Which
uh,
surgery?
uh,
Name the
mostly
surgery.
as it salpingectomy, sir. Salpingectomy, emergency salpingectomy.
Salpingectomy. Okay.
Yes, sir. Because it's
And
already ruptured. It looks like it's already ruptured. If it is not
okay.
ruptured, they will do evacuation or
How
salpingostomy
did you,
will be done.
what are the signs? How did you get to know that this is a rupture ectopic versus non-rupture ectopic? By history, you know, by examination, you know, by ultrasound, you know, or how you get to know that this ectopic is ruptured?
Based on symptoms and signs. Patient is having bleeding and the vitals are unstable, sir. BP is falling. Patient is in going for shock. So based on this
Hmm.
and
Fine.
ultrasound also we will know it's rupturing.
Mm.
We
So
already
what are
done
the
that.
findings? What are the findings in ultrasound in ectopic pregnancy? Can you tell me one,
Uh,
two, three? These are the signs of ectopic in ultrasound.
okay. absence of intrauterine pregnancy, and the presence of sac in the uh, adnexa, like in the tube or in the ovary or in the intra-abdominal also sometimes it can be, which will be seen on ultrasound.
Which is the most commonest site for ectopic?
Fallopian tube, sir. Tube is the most common site.
Which part? Fallopian tube has many parts. Which part of the fallopian tube?
This interstitium, I forgot.
I will tell you each
I
and
didn't
everything.
remember.
I want to know which part. Initial part, middle part,
I think
terminal part, fimbria part, where?
Sir.
In the middle,
What is the name of the middle part?
Sir.
intestinal.
Fine, no problem. That's fine. So that's it. This is your management. And if the patient is stable and patient has no this hypovolemia, no shock, patient has just abdominal pain, otherwise fine. Patient missed the period, pregnancy test is positive, USG shows there is a sac in the tube, fallopian tube. Patient is absolutely stable, blood pressure is 120 over 80, pulse rate is fine, 90, but she has severe lower abdominal pain or right abdominal pain, right? Immediate urine pregnancy test was done, it is positive, so you are thinking that, and you did a USG, confirm it is ectopic pregnancy. So how you manage this patient when non-rupture stable patient? Yes, Fatima. How you manage a patient's stable non-rupture ectopic? Yes, speak up. If you don't know, that's fine. You
But
just go ahead.
you
I don't
know,
know. Sorry.
if the patient is stable,
Yeah,
um,
patient is stable.
okay, we have to start the IV fluids,
Okay.
and if it is a non-ruptured ectopic pregnancy, and if the sac is intact and HCG is less than 3,500, we can go for medical treatment.
What contains in medical treatment? Can you name the medical treatment
Uh,
management?
is injection methotrexate,
Injection
50
methotrexate.
microgram
Okay, so you remember your dose, huh? 50 microgram. We will see it. What is the exact
microgram.
dose? 50
Okay, sir.
microgram per kilogram per day
Yes, sir.
or what?
Mm, not kilogram per day, sir. 50
Then how
microgram
you? Hmm.
once. IM once.
Okay, so let me write down your dose. 50 microgram. This is state dose, right? There is no milligram per kilogram or nothing, right? 50 microgram you have to give intramuscular to the patient. That is what you mean to say?
Yes, sir. Yes, sir.
Yes or no? Okay, fine.
Yes, sir.
Right. Then how you monitor the effect of this injection came or not? How you monitor?
Uh,
You had given the
we have
injection.
to.
How you know the response of this injections or medical treatment is working or not? Are you getting my question? Yes or no?
Yes, sir. Yes, we have to check for serial beta HCG, sir,
Okay,
for every
so
24
you
hours.
or every 24 hours, right? So after 24 hours, it does not get reduced, or what you expect? It should be reduced or it should be increased after methotrexate?
Reduce, sir.
Reduced. So after 24 hours, it is not reduced. Say for example, what will you do? After 24 hours, it's not reduced. What will you do? You think, Dr. Fatima? Yes, Salika. What do you do?
Um,
She had given the injections of methotrexate. After 24 hours, there is a
okay.
persistent pain. Vital is still stable, but patient saying, I have no improvement, nothing. And beta HCG is also not reduced after 24 hours. What you do?
Then Again, surgical management, sir. Surgical.
So you directly switch to surgical management. Hello.
Yes, sir.
So within 24 hours, you want to switch to the surgical management, Salika. Am I right or wrong?
Uh, we have to monitor HCG. HCG should be decreased, and
But it is not
the
decreased,
size
na?
is less. Yeah,
Size is
40,
not
48
decreased
hours,
and
sir.
HCG is also not reduced. Size is not reduced, HCGs are not reduced, pain, abdominal pain is not reduced. After giving 50 microgram intramuscular as per Dr. Fatima. So what you do? Are you getting my question? Yes or no?
Yes, sir.
Yeah. So what you do? Tell me. This is the question asking in the Oman Viva. You did it, right? It doesn't work out. Everything is same. What you supposed to do? What's your next plan?
Mm, I don't know, sir.
Sorry? Fine. Fair enough.
Sir, I don't know. Yeah.
Fair enough. No problem. So let's go and little deep dive into the scenario. So this is a case, right? It is given to you, right? One thing I would like to notice here, Dr. Fatima, for you, right? When the scenario is given, you don't need to repeat all the parameters again and again, right?
Yes,
Are
sir.
you listening me? Right?
Yes,
Because
sir.
it wastes your time because you spend 30, 40, 50 seconds in just describing the same thing. 28
Okay.
years, woman, this department, vitals are this. This is already given to you. You have to jump from this to next step, how you manage, right? So management contains initial investigation, initial stabilization, treatment. I told you one treatment is immediate treatment, what immediately you will do, and one is what is a causative, what causes this treatment of ectopic you have to do. I given you a lot of example of anemia and MI, isn't it? Yes or no? So immediate
Yes,
treatment
sir.
in any emergency would be ABC, airway, breathing, circulation or something, fix up or painkiller or analgesia if there, or IV antibiotic. This is immediate. This is immediate, right? But this will not cure the ectopic. For ectopic, you have to do something. You understand? So you stabilize the patient, any patient. Acute MI, you give Mona, morphine, oxygen, nitrate, aspirin. But after that, Mona will not open up the complete coronary arteries. You need to do something, right? So here we'll go stepwise. So don't repeat in the exam. Rather, you can say this is
Okay, sir.
better word. Better word by my experience is considering the clinical scenario, history, examination, and vitals. It finish in 5 seconds
Okay.
because she only had given you this, right? Then she will give you this paper that okay doctor, exactly the same paper you will give you, doctor, this is the case, right? You read it and you explain me how to manage this case. So everything she knows, you knows, right? So you don't need to repeat the again and again the what is vitals and all. Instead of that, you can considering the clinical patient's age, clinical history, examination, vitals, and positive urine pregnancy test. It is a suspected case and differential is ectopic pregnancy. Forget about rupture or non-rupture later on, but at least you must know it is complication of ectopic pregnancy, right? Ruptured. So diagnosis is not like ruptured ectopic pregnancy, right? It's a diagnosis is ectopic pregnancy. If you don't treat it, right, it may go into the rupture or it may present with the rupture, right? Both the way it's present. Are you getting me? Yes or no? Dr. Salika,
Yes, sir.
you both have to answer in that way. So you
Yes.
don't need to waste the repeat whole scenario and telling to her she has very limited time, he
Okay.
has very limited time. So don't waste your time because when you come to real answer is okay, fine. You hesitate, they go ahead, right? So just take 10 seconds pause, try to organize the answer in your brain, right? And then start considering the clinical history, examination, vitals, and finding. It is a strong suspected case of ectopic pregnancy. Is that clear? So let's see and dissect, right? So first of all, right, we would like to understand the basic things, right? So we would stabilize the patient. We send the investigation. You did not send tell me the list of the investigation. So basic investigations are always there, like complete blood count, prothrombin time as the patient is bleeding, basic liver function test, metabolic panel or renal function test, and most important is ultrasound. So now you need to know exactly what happens in the ultrasound because this is a game changer. CBC, LFT, renal functions, other tests will not give the diagnosis except the ultrasound. So ultrasound is absolutely important. Bedside ultrasound or transvaginal ultrasound. What you can see in the ectopic, right? Ectopic is not in the uterus. So obviously uterus is empty, right? This is the most important consistent finding. You can see if not seen in uterus, then where it can see? It sees the adnexal mass, right? And you may see the free fluid in the pelvis, right? So here the provisional diagnosis is ruptured right tubal ectopic pregnancy, right? That's all. So you need to just remember this, right? That what is seen in the ultrasound. So simple, if you don't remember, uterus is empty and there is a sac in the tubal or adnexal mass, right? So I will show you. Another is like what is ectopic pregnancy, we need to know. Implantation of fertilized ovum outside the uterine cavity, most commonly in the fallopian tube. I was talking about which part of fallopian tube? Ampulla, 70%. Ampulla, this is one side where 70% of the this fertilized ovum gets implanted in the fallopian tube, right? So rest of the things is 30%. So if they ask you where is the which site, commonest ampulla of fallopian tube. What are the risk factor? Previous ectopic pregnancy is one of the most important and highest risk factor. Highest risk factor. So all can cause this. But if they ask you which has the highest risk factor amongst all risk factor, previous ectopic pregnancy is number one. Pelvic inflammatory disease, tubal surgery, IVF treatment, smoking, IUCD, right? Endometriosis and prior pelvic surgery. So these are the risk factor. But amongst this, two are very important: previous history of ectopic pregnancy and pelvic inflammatory disease. So if you can go and read our scenario, there is a previous history of pelvic inflammatory disease. Each and everything is important in the scenario. Are you getting me? Yes or no? Right. So this is
Yes,
the
sir.
just at least be with me. Tell me yes or no. So I know that you are with me. So this is the risk
Yes.
factor. This is the picture, right? Just for the better clarity, what is exactly the ectopic pregnancy? So this is what the ectopic pregnancy. This is uterus, right? This is uterine complete cavity. So fetus should be here. Normal fetus should be here, right? But it is outside the uterine cavity. So this is from here it start the fallopian tube. So this is completely the fallopian tube. Let me take another color. So this is completely a fallopian tube, and this is ovary, right? So this is the ovary. So this part is the 70% most common, right? Ampulla, as we seen it, right? This is the most important part. So this is the fertilized ovum. It is in the fallopian tube. This is fallopian tube. Are you getting me? Yes or no? Right?
Yes,
So
sir.
this, yeah, this is the fallopian tube. So now let's little see nice, more nice picture, statistic pictures, right? So these are the statistically, just you need to know it's a very interesting picture. So I thought let me share with you. So this is uterus, uterine cavity, right? Interstitium of the fallopian tube, just 2 to 4% of ectopic pregnancy. Isthmus is 12%. So interstitium, isthmus, ampulla. This is the almost you can say middle part, and this is 70%. We already seen it. If you go a little down, so it can start from any part of the fallopian tube, either it is in the interstitial, isthmus, ampulla, right, fimbria. These are the this carries almost 80-90% of fallopian tube. Out of this fallopian tube, ovarian 3%, right, abdominal 1%, cervical 1%, cesarean scar, intramural 1%. So anything, anywhere outside the uterus, whether it is in the this part, down part, or right or left fallopian part, right? But 80-90% is in the fallopian tube in various part. The most common is the ampulla. Is that clear to you? Yes or no?
Yes.
Wonderful. Let's see the how do you diagnose the ectopic pregnancy. So clinical feature is extremely important. This is a gateway. This is how you suspect any patient comes to you. This is the number one thing, right? Without investigation, clinically, every patient you diagnose. There are two diagnoses. You can do clinical diagnosis, right? Clinical diagnosis. And you have a laboratory diagnosis, lab diagnosis. Clinical diagnosis, lab diagnosis, right? So lab diagnosis as well as clinical diagnosis. So what is a clinical diagnosis? Clinical diagnosis is something in which by history and examination you know, right? History and examination, clinical diagnosis you know. And lab diagnosis, by doing some lab you get to know that okay fine, this is the ectopic, right? So what are the clinical diagnosis? Amenorrhea, right? Lower abdominal pain, right? Amenorrhea, how did you get to know? Missed period, right? She missed period for last 6 weeks. Lower abdominal pain, strongest factor, and missed picture. So if you have just two symptoms, the amenorrhea and lower abdominal pain, until proved otherwise, rule out the ectopic pregnancy. Vaginal spotting, right? And in ruptured, maybe you see collapse or some syncope because of hypotension. So this is history. This is tell by the patient. I missed my period for 7, 8 weeks. I have severe abdominal pain. I have a spotting. I have a giddiness. Isn't it? Yes or no? Right?
Yes.
So, hello. Are you getting me?
Hello, sir. Yes, sir.
Right. So this is clinical history, examination. If it is rupture, hypotension, tachycardia, cervical motion tenderness, adnexal tenderness, we already seen it, right? So these are the clinical sign and symptoms you must remember and know. Second thing is that investigation extremely important, right? So this flow will not change for anything, right? Even in a real clinical practice, whatever, when patient comes to me, he tell his sign symptoms. I am this, I have this, that, right? Sign symptoms, mainly the symptoms, right? Then what I'll do, I'll examine the patient. After history, origin, duration, progress, basic past medical, surgical history, I'll examine the patient. So by compiling these signs, symptoms, and my examination, I have some kind of differential diagnosis, right? Maybe one, two, three. This is first likely, this is second likely, this is third likely, right? After this diagnosis, I will investigate accordingly to confirm the diagnosis. And once I'll confirm the diagnosis, I will treat the patient. And in treatment, there is an initial treatment where you stabilize the patient, all patients, and another is a confirmatory treatment or treat the cause, right? So you have malaria and you have 104 fever. So you can't say I'll give anti-malarial, I'll not treat 104 fever. You have to do both the things at the same time. Give the paracetamol, right? Give the antipyretic, immediately stabilize, hydrate the patients, right? And then start the anti-malarial. So do you did two things, right? Initial stabilization, curative treatment. Is that clear? Yes or no? Yes or no?
Yes.
Yes, sir.
Wonderful. So your flow should be like this only, right? So now comes to the investigation. You suspected this case of ectopic pregnancy. You suspected ectopic pregnancy. Now you investigating, right? So you first do the serum beta HCG, right? Human chorionic gonadotropin. In normal pregnancy, doubles every 48 hours. So this is the normal which you need to know. Doubles every normal pregnancy. So if you did it today 1000, after 48 hours it's 2000, like that it increases. In ectopic it is suboptimal rise. So in ectopic it is not going from 1000 to 2000, it could be 1500. Are you getting me? Yes or no?
Yes, sir.
Yes.
Transvaginal USG shows intrauterine pregnancy when beta HCG is more than 1500 to 2000, right? So this is what the thing is. So you need to know. So just simple parameter is beta HCG should be raised double in normal pregnancy, suboptimal is in ectopic pregnancy. That is good enough if you remember it, right? Second thing is TVS,
Yes.
transvaginal ultrasound finding. So we already discussed, right? So first is beta HCG is blood test, right? So you need to mention, you need to do the blood test, right? Investigation. Now you need to ultrasound. It could be per abdomen and transvaginal. So this is transvaginal ultrasound, right? So empty uterus, obviously, because nothing is in the uterus, it's outside the uterus. That is why the name comes ectopic. Adnexal mass, yes, plus or minus a ring of fire on Doppler. Ring of fire. This is one of the most diagnostic, right? You go and look into the picture of USG, right? How the ring of fire seen. So say this is a uterus, right? This is cervix. This is fallopian tube. So there is a ring. It's kind of ring at the ampulla. It's a ring of fire with some kind of hemorrhage outside. So ring of fire you can see on the ultrasound. So ring of fire is a diagnostic if it is present. And we already seen is there is a fluid in the pouch of Douglas. CBC is important because when there is a rupture, there is a bleeding, there is a low hemoglobin. So HB should be low. So CBC is a baseline parameter, or sometime you do basic simple serum SGPT, creatinine, electrolyte, and blood group important because when the hemoglobin is low, patient is in shock. You may need a blood transfusion. So blood grouping and typing is also important. Are you getting me? Yes or no?
Yes, sir.
Yes, sir.
Wonderful. So going further, right? So you history examination, right? Blood test, ultrasound, right? We are finalizing the things, right? So you did it everything. Now you confirm that okay, fine. This is case of ectopic pregnancy. How you manage this patient? That is what our thing is. So any management, any disease, any medical condition or surgical condition, the management start with the stability in general. Anything, malaria stable or unstable, right? Acute MI stable or unstable, VT, ventricular tachycardia stable or stubborn, severe abdominal pain stable or unstable, you understand? So this applies to the all patients, not just the ectopic. So stability is extremely important. That is rather first question, depends on that your management starts, right? So ectopic pregnancy absolutely stable, management would be different. Ectopic pregnancy very much unstable, patient is in shock, right? Even though the same diagnosis, right? Same diagnosis, management differs. Am I right? Yes or no?
Yes.
Right? What
Yes,
does
sir.
it mean? Means you need to know stability, right? So how to manage this patient? So first step, assess the hemodynamically stability, right? So unstable, right? Patient hemodynamically unstable or stable. There are two questions. Either patient is unstable or stable. So unstable, immediate resuscitation means ABC, airway, breathing, circulation, oxygen. And when patient is unstable or rupture or hypotension, prepare for surgery, right? We'll see it in detail, right? And if patient is stable, that is fine. Primary, you go for the medical. If fails, then you think of the surgical treatment if medical fails, right? So let's say surgical management, like in this scenario, what is the case? So patient is hemodynamically unstable, right? Instability, right? Ruptured ectopic, signs of intraperitoneal bleed, right? Regarding rigidity was also there. High beta HCG, fetal cardiac activity present in the tube, contraindication. So these are the indications. Surgical management, like in this scenario. So where you need to remember this all parameters when you supposed to go for surgical intervention. When patient is hemodynamically unstable, ruptured ectopic, signs of intraperitoneal bleeding which cannot be stopped by methotrexate, high beta HCG, fetal cardiac activity is present in the tube, right? And contraindication to methotrexate because of some methotrexate contraindication. Say, for example, this patient has a severe myelosuppression, or this patient is aplastic anemia and now develop the ectopic pregnancy. What you do? Right? In that case, usually methotrexate is contraindicated. So major liver myelosuppression or major liver dysfunction, methotrexate is usually contraindicated. Right? And in surgical procedure, you gonna do two things: salpingectomy or salpingostomy. There is a difference. Salpingectomy means you completely remove the one side of the fallopian tube. You remove it completely. So if tube is severely damaged, right? Or if the tube is severely damaged, you can do salpingectomy, or family is complete, 2 kids, 3 kids, there is no planning. You can do salpingectomy. It's irreversible. You remove the tube, it's gone. And salpingostomy means if fertility preservation is desired and tube salvage is desired. Primary gravida, ruptured ectopic pregnancy. You can't remove the tube, right? She needs kids, right? Though there is a opposite side is there, but still, I mean, patient's concern, you go for salpingostomy. So depends on the condition, right? But these are the two procedure we need to keep in mind. So these are the indication. Let's see what are the medical management or methotrexate. So criteria for methotrexate important for viva question. When you supposed to think like the surgical, when to do surgical, now when to do the medical. So hemodynamically stable, fine, you are not in hurry to operate this patient. There is no rupture, no intra-abdominal bleeding, fine. Beta HCG, remember the range, 5,000, not 3,500, 5,000, less than 5,000, you can wait and watch. Adnexal mass is less than 3.5, right? You can still do the larger tumor more than 3.5 or 4. You probably not get successful compared with surgical. So everything is important, right? No fetal cardiac activity, right? And patients reliable for the follow-up and monitoring, because when you do the medical management, you need to see the response. You need to see what happens to beta HCG after 24, 48, 72 hours. Will see, right? So here your dose was wrong, Dr. Fatima. I think you told 50 microgram, if I'm not wrong. Am I right or wrong?
Yes, yes, sir.
So
Yes, sir.
this is the indication where you supposed to do the medical management. This is the indication you need to remember. Second things comes, right. So what drug? Lots of questions for methotrexate. What we are covering? Indication where you supposed to give the methotrexate. Second thing is what is the dose. Third question is what is the route of the methotrexate. So everything comes gradually. So single dose methotrexate, not microgram, it is milligram. So it's a huge difference between microgram and milligram,
Okay,
and it is not the
okay, sir.
not the stat dose, 50 milligram per meter square. So what do you mean by meter square? Meter square can be calculated on height and weight, and the BSA comes. Do you know BSA? Body surface area, right? So if
Yes,
we
sir.
calculate
Yes.
our body surface area in average in Indian, 1.5 meter square. So if the BSA is 1.5 meter square, 50 multiplied by 1.5, it is 75 milligram. Are you getting me? Yes or no? At least tell me yes or no.
Yes.
Yes,
Yes,
sir.
sir.
Right. So per 1 meter square, 50 milligram. If the meter square is 2, 50 multiplied by 2 is 100 milligram. Are you getting me? Yes or no?
Yes,
Right. So
sir.
Yes.
dose is absolutely important. And once you deliver the dose, how you supposed to follow up this patient, whether methotrexate is acted or not, working well or not. In that case, follow up is important. Right. Measure beta HCG on day 4 and day 7, not 24 hours. Measure beta HCG on day 4 and measure on the day 7. Right. How you get to know whether you are successful or methotrexate is working or not? There is a criteria. Successful if more than 15% drops between 4 to 7. Are you getting me? If the if
Yes,
the
sir.
if the
Yes, sir.
2000 HCG level was 2000, you had given the methotrexate, 15% of 2000 is like 300. So now this become in 1500. It's supposed to be 730 per 15%, but so it is going very nicely down. Responding. Are you getting me? Yes or no? 15%
Yes.
more, right? Successfully more than or equal to 15% drop in which beta HCG at the end, right? So today you did a 2000 beta HCG, and after 4 days it becomes 1000. So how much is the reduction? 50%. So it's a good response. You need minimum 15%. So if the more than 15% reduction is there, your things are acting well. You can wait and watch. You can monitor. Methotrax that is working. Are you getting me? Yes or no?
Yes, sir.
Yes.
Right. Another question. What if this is not reduced? What if it is not reduced after 7 days? Drop between 4 to 7 days. So you are like a patient is stable, coming every day. That is why this is important. Patient reliable for follow-up and monitoring. So when you think that patient cannot reliable and monitoring, right, you cannot do the medical management. This all criteria should met, right, before. Why? Because you need a method. That how you monitor the patient when they are not coming to the follow-up. Are you getting me? Yes or no? Right. So you need a
Yes, sir.
proper follow-up. Patient should be well educated, or he has to comply or the advice of the doctor, right? So the you right probably is living like 200-300 kilometers away from your hospital in very remote area which she cannot come. This non-rupture stable patient may rupture after 5 days, right? And the ectopic getting bigger rupture, he may risk the life, right? So if the follow-up is not reliable in ectopic, you operate it safer side, you operate it, don't worry, right? So we have seen the indication, we have seen the exact dosage, 50 milligram per meter square, right? Not the microgram. Follow-up is extremely important. What you supposed to look into follow-up is more than 50% reduction in the beta HCG between 4 to 7 days. So there are two answers. Yes, it is reduced like 2000 to 1000, it is reduced. Another scenario, no, it is not reduced. It is still 2000. What to do now? What to do now? So there is answer for this, right? Which you did not answered me while I was asking you. So this is the answer. How to counsel the patient? So complication of pregnancy, right? So that is second thing, right? So we'll see it. So these are the high yield question in Oman Viva. We'll complete that questions, don't worry. So high yield Oman Viva questions and answer. Quick question, they may ask you, what is the most important risk factor for ectopic pregnancy? Beyond that, okay, fine. You diagnosed ectopic pregnancy. Can you tell me what is the most common risk factor for ectopic pregnancy? I told you already, previous ectopic pregnancy is the strongest risk factor, and after that, pelvic inflammatory disease would be the another most common, right? Why beta HCG is useful in ectopic pregnancy? It rises abnormally, right? So rise is low in normal pregnancy, as I told you, right? It increase or it doubles every 2 weeks. It doubles every 2 days, right? Are you getting me? Yes or no? Are you getting
Yes,
me?
sir.
Yes or no? So
Yes, sir.
normal, the
Yes, sir. Yes, sir.
HCG double in 24 hours, where in ectopic it will not double in 2 hours. So abnormal rise, less than 53%. Here 100%, double. 100 level become 200. After 48 hours, 400. Here ectopic it will 100, then 125, slow rise, 200 like that. Not double in 2 days. That is ectopic. What is the discriminative zone? You don't need to remember now, leave it for now. When do you choose laparotomy over laparoscopy? Hemodynamically unstable or massive intrahand, right? So when you do the laparotomy means this is chest, right? This is abdomen. So you make complete scar on the abdomen. This is umbilicus. So completely from xiphi sternum to symphysis pubis. You make a big incision in the center of the abdomen, passing from the tummy, from the umbilicus, it is laparotomy. So laparotomy is usually done when hemodynamically unstable, right? You don't know how much is the rupture, any other cause, where is the bleeding in the peritoneal cavity, confusion, right? Right? And patient is stable, patient is fine, patient is absolutely. In that case, you can go for the laparoscopy as well, right? So laparotomy and laparoscopy, the goal is same, right? But when patient is hemodynamically instability, right, at that time probably laparoscopy needs some kind of surgical expertise. Laparoscopist is required, which may not available immediately. So you don't need to be hero. Open up open up laparotomy, open up, that's it. And by laparotomy you can see whole the abdominal cavity complete visualized while you open up, and then you can treat the patients, right? So this is what the thing is. Before going further, this is the summary. So below is a clear exam oriented flow chart for the ectopic pregnancy management. So let's see very quickly once again. Ectopic pregnancy management flow chart, medical versus surgical. So how you manage this is, so once you history, examination, ultrasound, you suspected this is ectopic. So how you suspect? Positive pregnancy test, history, pain and spotting. You did ultrasound, TVS, transvaginal ultrasound, right? Ring on fire is there, empty cavity is there, there is a, right, there is a adnexal mass is there, beta HCG is rising or high, right? So this is ectopic. Is the patient hemodynamically stable, right? Unstable or shock? IV fluid, immediate resuscitation, IV fluid, right? Blood grouping and cross matching. If the hemoglobin is severely low, you can transfuse. Oxygen monitoring. Emergency treatment, laparotomy, as I told you. Right, patient is hemodynamically unstable, you open up. No role of methotrexate. In unstable, no role. If you give methotrexate, you wait for 4 days, 8 days, 7 days, whether increase, decrease, doesn't work out, right? 7 days he may die, she may die, right? So you need to operate it. There is no role of methotrexate in unstable patient, right? It is role in the stable patient, right? So what is it, right? So check the methotrexate eligibility, right? So methotrexate, so surgical we have seen. Simple. Surgical, patient unstable, you suspect ruptured, right? Open up. That's it. Patient is stable, otherwise fine, no emergency, everything is okay. You can go for methotrexate. This is the acronym safest criteria. Safest. What is safest? Right? Where the if you match this safest criteria, you can use the methotrexate. What is safest? Patient is stable. So this is S. A means, right? Instead of beta, they make it here A. Beta HCG less than 5, right? F means no fetal activity. E means ectopic size less than 3%. S means sure for follow-up. Patient, I told you, when you give the methotrexate, right? Methotrexate, when you give it methotrexate, patient supposed to follow you, right? It is 50 milligram per meter square. Once again, to remind you, right? It should be given intramuscular. Once you give it, there should be a appropriate fall after 4 to 7 days, and for that patient has to come to the hospital. As patient is stable, you discharge. You can't admit her for 4 days, 7 days, right? So she discharged, but she's supposed to come back for follow-up. Sure follow-up is available or assured, right? And T means right no methotrexate contraindication. Methotrexate contraindication should be not there, right? So what are the contraindication? I told you, right? Renal, severe renal and liver dysfunction, severe myelosuppression or bone marrow suppression, because methotrexate further suppress the bone marrow. Patient is on breastfeeding or immunodeficiency, right? Because the immunity is low, and if you give methotrexate, it may further go down and may have some kind of risk or increase the risk of some infections, right? So if no contraindication, so patient stable, beta HCG less than 5%, fetal activities or fetal cardiac activity is not there, right? Patient is size, ectopic size is 3.5, follow-up is sure and no contraindication. If all criteria met, you go for medical management. All criteria met, you go for medical management. So you need to do, right? So whenever patient comes, right, first question is what? Patient is stable or unstable? What is the beta HCG, right? What is the USG, right? So USG will give you two idea. What is the size and cardiac activity is there or not? And patient is sure. That's it. Simple. That's it. That's it. So if it is there, then you can do it, right? So you can do it, right? So in that case, or management, you can do the monitor things. Medical management, methotrexate, 50 milligram per meter square intramuscular, follow 4 days and 7 days. If successfully rise more than 15%, it's working, right? If not, our question was not very important. They may ask you, you had given the methotrexate, no improvement. What are you supposed to do? Give the second dose of methotrexate. Patient is stable, but you did not get the expected result of this. There is a no fall of more than 15%, right? In that case, because patient is stable, you want to chance once again conservative. Give second dose of methotrexate. There are two questions. Yes, it is responding. Method right. HCG is going down. What if there is a no response? Again, you have the 7 dose. Then you don't need to think anything. Surgery, right? If patient symptoms are worsening, patient is not getting better, you go for surgery, right? So this is what the standard algorithm, right? So that's it. And the special situation. There are some special situations where you supposed to do. What do you do? Live ectopic with cardiac activity, surgery preferred. No cardiac activity, medical preferred. Cardiac activity, right? Because methotrexate failure risk is very high with the cardiac activity. That is the reason why surgery is preferred. Second, HCG is very high means tumor bulk probably the more, right? In that case, usually the size is also more, so preferred surgery. And interstitial or cervical ectopic, methotrexate sometimes used, but specialist management required. So in that case, where you supposed to do it. So concluding our talk of whole the things what we did it so far in last 1 hour is this, right? Visualize flow chart, right? Text based. So first of all, sign symptoms, pregnancy test is first test, pregnancy test is positive, right? And pain or spotting is there, abdominal pain, mild vaginal bleeding, positive pregnancy test means suspected ectopic pregnancy, suspected. How you confirm? Transvaginal ultrasound and beta HCG. You did it. Transvaginal ultrasound, what shows? Cavity is empty. There is a adnexal mass and ring on fire. These are the three things we have seen it. It is seen in the transvaginal. Beta HCG is also high. That confirms the pregnancy. So ectopic pregnancy is confirmed by hormone level and by ultrasound on a suspected case of pain, spotting and positive pregnancy test. Now next questions, once you confirm the ectopic pregnancy, these all are what? Sign symptoms, pregnancy test, ultrasound and beta HCG and basic blood test. You confirm it. It is confirmed. Now, next patient. Patient is unstable or patient is stable. If patient is unstable, resuscitate means immediate treatment, and specific treatment is surgery. You do emergency surgery. You can't wait in unstable patient. What if it is patient is stable, right? So check the methotrexate this eligibility. Sorry, right? So stable. You need to check the stable. What we have learned so far, right? So we need to see the criteria, right? So whatever patient methotrexate ability means what? Patient stable, tumor size is less than 3.5, beta HCG is less than 5,000, right? Also you have seen there is a strong follow-up, right? So this should be there. If it is there and there is no contraindication, there is no contraindication of methotrexate, so all eligibility is okay now. So all methotrexate criteria met? Yes, it met. Then what you need to do? You need to give methotrexate 50 milligram per meter square intramuscularly given to the patient, right? And day 4 and 7 you follow up. There are two answers, right? This HCG is reduced or HCG is not reduced or increased, right? So if it is reduced, right, the answer, right, continue follow up, it's working, right? And if less than 15% reduced, right, means one is reduced, continue. If not reduced, second dose of methotrexate. If reduced, follow up. If not reduced, surgery, right? So that's it. This is what the management of ectopic pregnancy. So in nutshell, I think almost all covered the important part of the ectopic, if I'm not wrong, right? So this is how you have to present in the exam. You need to know and have the clarity of the ectopic pregnancy, how we diagnose, how they present, what is the commonest site, right? How the clinical history, examination, investigation, how you manage stable, unstable, what are the criteria of methotrexate versus surgery, and that's it. So these are the key high yield questions they're gonna ask you in the exam, and this is beautiful chart. I think I got it. So that's it from my side. Thank you very much. Now you tell me how did you enjoy it? How did you did the mistake, or what was the clarity in your mind before and after the class? Tell me one by one. Yes, Dr. Salika. Dr. Salika, you can unmute your mic. Your mic is mute. Yes, Fatima. How is your earlier concept, thought process, and now? Yes,
Very, very,
Fatima.
very clarity. The
Yeah,
class
go
is very
ahead.
clarity, sir. I didn't know the dosage actually. I know it is 50, but I was a
Fair
little
enough. See,
confused.
this is
Thanks
learning.
for
This is
the
learning.
clarity,
Don't
sir.
worry. Don't worry.
Yes,
This is learning. These are the small but important points they're gonna ask you in the exam. So I'm going bit in
yes,
detail,
yes, sir.
little bit about
Yes, sir.
dose, side effect, indication, contraindication, where to. Now we have complete mindset now, right? I don't think there is a confusion now, right? When
Yes,
patient
sir.
present, we knows, right?
Yes,
How
sir.
signs, symptoms present, USG, SCG, basic blood test, suspected, did sonography, did beta HCG, stable, unstable, stable what, unstable what, when to do surgery, when to do this, what is the dose. That's it. This is what they ask, isn't it?
Okay, sir.
Wonderful. So where did you think that you did some mistake, or what was the old concept and now new concept?
HCG numbers, sir. HCG
Sorry.
5,000. Now they have increased HCG to 5,000, right? Before it used
Mhm.
to be 3,500 or 4,000.
Mhm. Fine, fair enough. And how is the clarity overall for this subject of ectopic now?
Very good, sir. Very good. Very nice, sir. Thank you so much, sir.
Wonderful, brilliant. So we'll come up with the next class. I will keep you updated in the class as well as usual. So we'll cover everything. Don't worry. We don't need to. I can
Okay,
make it
sir.
in 20 days, 20 lectures, all done. You read it. Now you open up the book.
Okay.
Yes.
Again, open up the book. You both
Yes.
of you open up the book. Read the whole ectopic once again. Right? That makes you strong. Without revision, you will forget. Believe me. Without revision, you forget. Without
Yes.
revision, you forget. You must have to do the revision. Must have to do. Revision is very, very important. and preferably it should be done within 24 hours to prime your brain, right? Whatever you learn, whatever you are again doing it, it's little more stronger. After 1 week, you're doing more stronger. So this is how we can catch up all the important topics of the Oman Viva, right? So whenever I'm posting the things, you read it, you read it, so you can discuss more, right? Today you both looks better than before. Don't take it otherwise. So you answered well. You know the concept. You did given the most of the answer. Both of you did well overall, right? But I want you to look more into the pharmacological part, not very much in detail, but you need to
Yes.
know basic. If the renal colic is there, what drug you give, what dose you give, where you cannot give. That's it. This is simple. You understand? So it is a basic. Na? When somebody
Yes.
severe 9 out of 10 renal
Okay.
colic pain comes to you, what will you give to the patient? It's a basic question. It's not something very hi-fi question. But you need to know just diclofenac or NSAID is not enough. You need to know at least dose of one drug. If you say diclofenac, then examiner will ask you how much is the dose for adult patient who is 50 kg weight. You understand? You need to know only one, at least one drug, perfect dose. Methotrexate, perfect dose. Thrombolytic, perfect dose. Aspirin in acute MI, perfect dose. Are you getting me? Yes or no?
Yes.
Yes, sir.
Wonderful. So
Sir,
thank you
one
very
doubt.
much. Yes, please.
Sir, this so any pregnancy case if they are asking, so
They can,
we
they,
can say just
yeah, sorry,
if stable that uh, I mean
sorry. I'm not
gynecology
getting your
because
question.
gynecology is yes sir. If they in exam if they're asking about pregnancy cases, like
Mhm.
when we should say about gynecology, I mean treatment should be done. I mean scanning everything basic we can do, but still if as soon as we find ectopic pregnancy, we are going to refer only, right, sir?
Yeah, you refer only, but they have the liberty to ask you, okay, what drug you
Uh,
will give. That is at least they can
um,
ask you. Huh? You can't say, oh,
yeah, I
I
mean
don't know
the
methotrexate. Surgical part, they
yeah.
just win. See, I'm a hematologist. I got tomorrow acute myocardial infarction. But it does not mean I don't know the basic thing. Oh, I will not treat this patient,
Yes.
you take him away. I can't say that. I at least do ECG, I do enzyme, I give aspirin. That's it. This is what I can do. And what cardiologist will do? He will do the same thing. Okay, I'm not going to do PCI or angiography, angioplasty, bypass. Obviously, it's not right. But initial stabilization, initial diagnosis, you can do it, right? So
Okay.
ectopic initial things you can do it. You should know when to give and when to refer. This is what they wants to know. You are sitting in OPD or
Mm,
clinic, which is like little
mm,
far away from the major hospital in Oman or Muscat or Salalah, right? These are the main places, right? I know because I worked there for 3 years. So
mm,
it's a far center. So you can't say, oh, you refer him. She will die on the way. You need to stabilize. You take IV line, you give some analgesic, you need to some monitor, you place on the monitor, you call the gynecologist, you try to stabilize the patient, right? So and giving intramuscular methotrexate is not a very heroic thing. You can coordinate with the gynecologist. You can coordinate, na? You can coordinate. There is no crime that, oh,
yes,
why
sir.
you had given
Sir,
the
oh,
methotrexate.
okay. So, sir, if pregnancy related cases we can see in OPD also. Pregnancy, if any pregnant cases, like
Usually they
how
are managed by
rules here, sir?
gynecologist. No,
Which
most of
only,
them they are. Yeah, antenatal. So sometimes we'll see antenatal as well. Antenatal management
also.
of the patient. Young primary gravida comes to you. They will not every day going, say for example, hospital is 200 kilometers away from your place. So every week they may not go, na. So antenatal basic management, you should know what is the first trimester
Mm,
management, second trimester, third trimester, what are the clinical or critical red flag signs, right? How you diagnose, monitor blood pressure, gestational diabetes, urinary tract infections, hyperemesis gravidum, right? Or there are a lot of hundreds of things in the antenatal, right?
everything.
So basic monitoring can be done at GP. Basic monitoring can be done at
Okay.
GP, right? Obviously, you can't
Okay.
do cesarean section or forceps delivery or even normal delivery, but you can monitor the patients, na? Right? So
Yes.
say for
So
example,
till
patient
that
of
we can
diabetes.
say. Oh,
Yeah, initial when patient of diabetes, say for example, comes to the OPD, right? So every time he will not see the physician or endocrinologist, right? They will prescribe, they will do that, okay, take insulin this time,
Yes.
take metformin, blah, blah, blah. But regular monthly follow-up, you can do it. So you know what to see, what are the side effects of
Yes.
metformin,
Yes.
what patient properly taking dose or not, right? How is the compliance? This is all the general practitioner can do it, right? So
Yes.
that's it.
Same
You
like
got it.
India. We
So
can.
sorry,
Yes. Like
you got
India,
it or
like
not?
how we do in PHC and yes, sir. Yes.
Yeah, yeah, that is what we do it at PHC, Primary Health Center in India also, right? If you feel that, oh, this is a very critical or something life threatening, stabilize, refer.
Refer.
Initial stabilize,
Okay.
refer,
Thank you so much, sir.
right? So just
Thank you,
keep
sir.
in
Thank
touch.
you so much
Thank you
for
very
the
much.
good explanation.
We'll keep in touch and I'll posted you in the things, right? Dr. Fatima, is that all clear to you?
Yes.
Thank you, sir. Yes, sir.
Wonderful. So just revise it and I'll keep in touch with you. Thank you very much and enjoy your day. Thank you.
Yes, sir.
Thank you very much.
Thank you.